your station. Right, so if you have read and understood considering its surgical anatomy station, kindly tell me, yes, what are you looking at? What is this organ, one over here, if you can identify with my cursor? Yes, one.
I think one is aorta, abdominal aorta.
Abdominal aorta. Can you please tell me at what level aorta becomes abdominal aorta, or is it called abdominal?
At T12, T12.
T12, okay. Can you please tell me what are the branches of abdominal aorta?
It's a single branch, like celiac and superior-mesenteric and the inferior-mesenteric artery.
Okay.
And the medium sacral artery, and the
Yes.
birth branch, like inferior phrenic arteries and renal arteries, gonadal arteries, and 5 lumbar arteries, and its distal branch, iliac arteries.
All right, good. Can you please tell me which of these branches of abdominal aorta supply gastrointestinal tract?
What, please, again?
The branches that you have mentioned, can you please tell which one of these abdominal aorta's branches supply gastrointestinal tract?
Branch, celiac, and superior mesenteric and
Superior.
inferior mesenteric.
Yes, very good. Okay, can you please tell me at what level celiac artery arises or comes?
At T12.
Very good. And what is the characteristic of superior mesenteric and inferior mesenteric arteries?
Characteristic
Level of arrival? Yes.
Superior mesenteric at L1, and
yes.
the inferior mesenteric and at L3.
L3. Yes. Can you mention some other planes or organs which are present at the level of L1? Why L1 is, yes.
At L1, it's transpyloric plane. There is a pylorus and right and fundus of gallbladder and the costal margin rib 9, and there is
can you identify number 3, please?
Number 3, it's right distal branch is the right iliac arteries.
Okay, and then if you can identify number 7 over here, please.
Right external iliac artery.
Okay, right. Can you identify number 23 over here at the back?
Inferior vena cava.
Very good. What is number 4? Kindly identify.
Right common iliac vein.
What is number 8, please?
Right external iliac vein.
Can you please tell me all the tributaries of the inferior vena cava, please?
Inferior vena cava, both inferior phrenic veins and hepatic veins right suprarenal vein, both renal veins, right gonadal veins, فوق الفيفث lumbar veins, والمين tubules, both right and left common iliac vein.
Okay. And at what level inferior vena cava traverses and enters the thorax?
L5.
L5.
I say again, please.
At what level inferior vena cava enters the thorax?
Thoracic A.
Yeah. Okay. Can you please identify? Yes, this vessel. What is it? If you can identify.
It's a right renal vein.
Okay, and any of these, if you could identify.
Severe mesenteric.
What could this be?
The right gonadal vein.
Okay. Good. Good. If you can tell me what kind of image is this that you're looking at, please.
It's angiogram of aortography.
Okay. Can you please tell me if you can identify these structures from A to K L?
A.
L. What is A, please?
A, it's abdominal aorta.
Okay. What is B, please?
B, right common iliac artery.
Okay. C, please.
Left common iliac artery.
Okay. D, please. D is here.
Left renal artery.
Okay, please. Good. E, please.
A, right renal artery.
Yes. F, please.
F, splenic artery.
Yes. G, please.
G, it's common hepatic artery.
Yes. Good. H, please. H is here.
H, right gonadal, right superior mesenteric artery.
Superior mesenteric artery. Yes. I, please.
I, gastroduodenal artery.
Yes. J, please.
G, left hepatic artery.
Yes. K, please.
Right hepatic artery.
Yes. And the last one, L, please.
L, inferior mesenteric artery.
Okay. In what kind of conditions would you ask for this investigation?
Again, please.
In what kind of conditions of abdominal aorta would you ask for this imaging?
In abdominal aortic aneurysm.
Aneurysm. What type of aneurysms are there?
It's true aneurysm.
Yes, but there are true and false aneurysm classified. Okay, can you please define aneurysm?
It's a dilatation of the arteries, of the arterial wall.
Okay, can you please tell me what is the cause for aneurysm to form? What is the pathogenesis?
Saccular.
Yes.
Saccular of
yes, it could be like pathogenesis could be like true aneurysm or post-traumatic or false aneurysm. Can you mention few risk factors which can cause aneurysm, abdominal aortic aneurysm to form?
Infection, autoimmune.
Yes, and hypertension, the most common one.
Yes.
Yes. Okay, Bell has gone, but can I ask you what, if you can define what you understand by the term dissecting aneurysm?
It's a separation of arterial wall layer.
Yes, with?
Will lead to ischemia.
Distally, it can lead to, yes. All right, okay.
And the sclerosis.
Yes. Okay, if we can come to the last image, can you please tell me these 1, 2, and 3 arrows are pointing at something? Can you identify these?
Mark again.
Yes. Can you tell me what kind of image is this? And this arrow and this one and this one, 3 arrows are pointing at something. What is this?
Aortic aneurysm, circular.
Okay. So this is what type of imaging is this? Done at the level of lumbar region, or because this vertebra is the lumbar vertebra? Can you see, can you give an idea at what level, at what landmark this image has been taken?
I think it's L1.
Yeah, one can say transpyloric plane. Yes.
Yes, there is
Yes.
a supramesenteric artery which come transverse longitudinal with aorta and
Yes.
and both kidneys and liver and spleen.
Yes.
And L1 there is identification of aortic aneurysm on L1.
Yes. Good, thank you. Just one last. Okay. Right, so if you are read and understood, considering a clinical examination station, kindly begin.
I will wash my hands. I will enter the room. I will enter the room. I will wash my hands. I will introduce myself. Good evening. I'm Dr. Kuldeep, one of the surgical candidates. May I know your name and age, please?
Yes, I'm 40 years old, Tina.
Nice. Today I've been asked to examine your back and leg, which includes looking, feeling, and moving your leg. Is it okay with you?
Yes.
This examination, now I will observe your walking pattern. Is it okay with you? Can you let me know, do you have any pain right now?
Not that much, I can bear it.
Okay, thank you. Can you just walk towards the end of this room, please?
Okay.
Okay, thank you. Can you just walk on your toes, please?
Okay.
Can you walk on your heel, please?
Yes.
Thank you. Now, Tina, I will take a close look at your back. Is it okay with you?
Okay.
Now I will look at the back for any scars, any wasting, any spasm, any tuft of hairs. Now I will look from the side. Tina, I want to look at your back from the side. Is it okay with you?
Yes.
Now I will look at the cervical lordosis, thoracic kyphosis, and lumbar lordosis. Tina, I want to look in front from the front. Is it okay with you?
Yes.
Now I will look from the front. The head is in center, or there will be any shifting division of the body from in the midline. Thank you. Now I just want to examine. I just want you to do some movements for me. Is it okay with you?
Yes.
I just want you to bend forward.
Yes.
I just want you to bend backward.
Right.
I just want you to touch your bend towards side and try to move your arm below the knee.
Yes.
Now, Tina, I will mark a few points on your lower back, and I will ask you to bend forward. Is it okay with you?
Yes.
I will do this is called as Schober test. I will do a modified Schober's test. I will first feel the posterior superior iliac spine, and then I will
Yes.
mark a 10 centimeter above and 5 centimeter below. Then I will ask the patient to bend forward. Tina, can you bend forward for me?
Yes.
Normally, this distance should increase more than 20 centimeter. If it is not increasing more than 20 centimeter, it can predispose to inflammatory pathologies like ankylosing spondylitis.
Very good. Yes.
Tina, can you lie down for me?
Yes.
Thank you. Tina, now I will move your legs. I will ask you to perform few actions, and I want you to resist me so that I can check your power of your muscles. Is it okay with you?
Yes.
Tina, I just want you to raise your thigh, and I will try to push it down. Don't let me do that. Can you do that?
Yes.
Can you push your thigh down towards the bed? I will try to raise. Can you do that?
Yes.
Don't let me do that. Can you just straighten up, bend your knee, and I will try to straighten up your knee. Can you do that?
Yes.
Can you just bend your knee, please? I will try to straighten up. Can you do that?
Yes.
Can you just cock up your feet towards your face? Can you do that? I will try to push it down. Can you resist me?
Yes.
Can you push my hand downwards?
Yes. Continue.
Can you just extend your? Can you just cock up your great toe towards your face? Can you do that?
Yes.
Now, thank you. Now, Tina, I will check you the sensory part of my examination, which include I will touch your forehead or your chest with a wisp of cotton, and then I will ask you to close that, and I will touch in a specific portion of your lower limb to check whether you are able to see whether you are able to feel it or not. Is it okay with you?
Yes.
Now, with the wisp of cotton, I will just touch over the forehead or the chest. Then I will check. I will ask the patient to close her eyes, and I will examine in a particular area, like in L4 on the middle mal, S1 lateral border of the foot, over the dorsum of the foot, L5 distribution, and over the anterior thigh for L1, L2, L3. Is it okay with?
Yes.
Now I will Now I will check the I will now tap. I will do the tap. I will tap your I will tap your hip and knee joint. Is it okay with you?
Yes.
Now I will tap for knee and ankle reflex, and along with I will check for the plantar clonus. Tina, I just want to ask you: do you have pain in your hip and knee joint?
No, not that much.
Tina, I will raise. I just want you to be relaxed. I just raise your right lower limb first by cupping the ankle joint in my hand, and I slowly raise. I just let you know when you have a pain, and
Yes.
then I will slowly dorsiflex your ankle. It will increase your pain, but I will then release it, or I will bend your knee slightly. It will also help you to in relieving your pain. Is it okay with you?
Yes.
If the patient has first of all, I will do on the right side as a patient in the history given in the left side. First, I will do on the right side, then I will do on the left side. If it is positive, it is active SLR test. If the time
Yes. Can you
to do,
summarize your examination now?
if the time permits, I want to do leg roll and leg lift, and I want to do the femoral stretch test, and I want to do the SI joint examination.
Yes.
Today I have examined a 40-year-old waitress by ACUTE patient who presented with a back pain, and on examination she has a tenderness over the lower back, and she has a left active SLR with normal neurology, no motor weakness.
Good. So
With
what
no
are your
bowel movement.
differential diagnosis for her?
My first differential will be a lumbar prolapsed intervertebral disc at L4, L5 or L5S1. Second will be a lumbar canal stenosis, and
Yes.
third will be a metabolic disorder.
All right. What investigations would you ask for this patient?
I will investigate the patient with the labs in form of full blood count,
Yes.
ESR, CRP, as well urea electrolyte, and along with X-ray radiographs, standing X-ray radiograph, AP and lateral view.
Okay.
Screening with dedicated lumbosacral spine.
What are the treatment options that can be offered to this patient?
I will has no neurological deficit. I will discuss the patient in multidisciplinary board, including orthopedic surgeon pain physicians. I will start the patient on conservative treatment, strengthening exercise, and physiotherapy, and analgesic and muscle relaxant.
Very good.
If patient doesn't improve, then we can go for discuss the options for surgery.
Okay, good. Right. Good. Thank you. Yeah, so question answer. Okay. Right. This is it was good. One small thing I want to ask you. You did not tell me how much exposure you wanted of the patient. And with regard to
Ma'am,
that,
I forgot.
yes, you'll only have this patient, these kind of scenarios, patient in only shorts, since it's a female. So you would have
For the
asked her,
chaperone.
yeah, yeah,
Yes, ma'am.
which you didn't ask.
Sorry,
So
ma'am.
you
I
have
missed
to
that.
consider the gender. You have to
Yes, ma'am.
consider the exposure, because exposure is very important. With
Yes.
exposure, you will have to consider the gender and then ask the chaperone.
Yes,
If
ma'am.
examiner
Definitely.
says consider, examiner is your chaperone, then you can go ahead and consider. And when you were examining, my little worry that you have to ask the patient, once you're doing, you're asking the patient to do the active movements and everything, then you have to look at the face of the patient as well. If patient is experiencing pain or anything, and you can say, okay, if it causes you pain, or if it's all right, would you be able to go ahead and do this? So like in a this kind of way.
Ma'am, actually, I just want to do that, but I thought because the time constraint, I just want to
Yeah.
complete my examination, because
I know.
I have to ask also that
Just once.
unfortunately,
Yeah, if you
unfortunately,
mention
I'm not able to complete it
exactly,
actually.
you couldn't, but then you mentioned it at the end. If time would have allowed me, I would have done this. So that kind of you covered. But like saying it, because now I cannot see, and I cannot
Yes, ma'am.
imagine when you'll be doing examination on the patient, would you be doing it? I'm sure you'll be doing it, because this is what you do. But
Yes,
just
ma'am.
saying. Thanks.
Yes, ma'am.
Question. Sorry, was adding him. Right. So if you have read and understood, considering with history taking station, kindly begin.
Hello, my name is Dr. Mamoon. I'm one of the exam candidates. May I confirm your name and age, please?
Yes, my name is Linda, 35-year-old female.
Nice to meet you, Mrs. Linda. Today, I've been asked to ask you a few questions regarding your condition. Will that be okay?
Yeah, sure.
Okay, how can I help you today?
Doctor, for last 1 to 2 days, I have a tummy which is present in the middle, in the
Oh,
upper part, just above the navel.
oh, I'm really sorry to hear that. Could you tell me when you noticed this for the first time?
Yeah, I think it's just 1 day only, doctor.
Okay, does this pain move anywhere?
Yeah, it is going to my back also.
Okay, is this pain started suddenly or gradually?
Doctor, it started suddenly actually.
Okay, is there any specific time during the day which the pain be increasing?
No, no, no. There is no like that. There is nothing like that. It is present, doctor. I mean, it's too much of pain right now.
Okay, is there? Oh, I'm really sorry to hear that. Is this pain is come in goes or worse than before?
No, doctor. It was started since 1 day only.
Okay, is there anything which make better the pain?
Doctor, sometime when I sit and lean forward, sometime I get better.
Okay, okay. Is there anything which make worse the pain?
Yeah, if when I lie down, it hurts me a lot. I'm not able to sleep for last night.
Oh, I'm really sorry to hear that. So could you please rating me the pain from 1 to 10, and the 10 is being the most worst one?
I think it's 9, doctor.
Okay, could you please describe me the character of the pain? It's like a colicky type, dull, cramping type.
I think it's a sharp pain, doctor.
Okay, how the day-to-day life has been affected by this pain?
Yeah, doctor, I'm not able to sleep.
Okay, is this pain is radiate to the backside?
Yeah, I told you.
Okay, as you mentioned, this pain is relieving when you're leaning forward. Is it
Yeah,
okay?
yeah, you're right.
Okay, uh, okay. Is this pain is radiated to your right shoulder?
No, no, not yet, doctor.
Okay, have you noticed any yellow discoloration up your skin or up your eye?
No, doctor.
Okay, is this pain increasing when you're taking some fatty meal?
No, doctor.
Okay, do you taste sensation, taste of acid in your back up your mouth?
No, doctor.
Do you have any heartburn in your chest?
No, doctor.
You vomit?
Yeah, I had 3 episodes in the past, and I total have a
Oh, I'm really
feeling of, yeah, I will throw up. Whenever I ate something, I feel like I am throwing up.
okay. I'm really sorry to hear that. Is there any blood when you vomiting?
No, doctor, there is no blood.
Okay. Do you have any pain in your chest?
No, doctor.
Okay. Have you been investigated before for cardiac problem?
No, doctor.
Okay. Have you visit any GP due to any other medical condition?
No, doctor. No.
Okay. Have you had any surgery before?
No, doctor.
Do you take any medication?
Yeah, my GP has given me some medication. He told me
Could you please
to
tell me
take
the name?
this for, I think it's morphine.
So,
He told me to take this medicine
so could you
for
please?
my pain relief.
Okay. Okay. Could you please tell me about the dose of the
I don't
morphine?
know. I take that
How many
tablet.
tablets you?
I don't know. I
Okay.
took
Okay.
all my thing.
Okay. Okay.
In
Do
the
you have
night,
any?
I took 1 tablet.
Okay. 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 Do you have any allergy against medication?
No, doctor, not knowing it as such.
Okay. Okay. Can I ask some personal question?
Yeah, sure, doctor.
What's your
I know. Can you
Uh,
please summarize the
doctor,
history now, please?
yes, this is Mrs. Robert, 35-year-old lady presented to us with the abdominal pain, which he's in the epigastric area. which is radiated to the backside from the last 3 days. And also there is association of vomiting, 3 upsets. And she also taking some medication for pain relief, like morphine, 1 tablet per 24 hours.
So what are your differential diagnosis for this patient?
According to the history, first of all, I would like to keep in mind acute pancreatitis. I will also thinking about acute cholecystitis, peptic ulcer disease,
Yes.
and I have to rule out myocardial infarction.
Okay, good. What are the investigations that you can suggest for this patient?
First of all, I would like to start from baseline, full blood count, LFTs, urea electrolytes, and some amylase lipase, ultrasound abdomen, and some other medication like cardiac markers to load MI and ECG, echocardiogram.
What are the treatment alternatives that can be offered to the patient?
Treatment. So for the management, first of all, I will follow the CREST protocol ABCD. After following the CREST protocol, I will for the pain, I will go for morphine, and I will also keep in mind some prospect antibiotics and
About morphine, what should be the normal dose which a
yes,
patient
madam.
should take?
From 20 to 30 milligram per day.
Per 4 hours. Okay, right.
For 4 hours, yeah.
Yeah, since it
Okay.
was not, it did not come from the history that you could have ruled out that patient was taking more morphine than it was prescribed. So second part of the management couldn't have been taken place. But one thing was you didn't even get to that point where you could have asked about the personal questions that if patient drinks or smokes. So here patient is
Yes, madam.
alcoholic. So that is the reason why patient has acute
Yeah.
pancreatitis. In the management, once you've already told me everything, then you have to send a one request letter to the dependency unit as well, because you have to manage patient's alcoholism as well. And then
Yes, madam.
yeah, so that little part of management was missing.
Yes, madam.
Psychologist or something you had to involve. So yeah, good. All right, and one more thing, because another great part of history taking that you have missed was idea, concern, and expectation, ICE. So at the end, when bell goes and you're not even done with the history completion, then you can just completely say it. If time would have allowed me, I would have asked about the idea, concern, and expectation, and then begin. Okay, today we had Robert, and she presented with this and this. So that's another way of earning points. You can give a message what you missed, so you just say it, so examiner would know that you knew it. You just didn't get enough time to complete the history. Good. Yes, Dr. Abbas has.
Yes, madam.
Right. So if you have read and understood, considering it clinical communication skills station, can we begin?
Good afternoon, sir. I am
Good
one of the
afternoon.
candidates for this. My name is Dr. Nwachuku. I am one of the candidates for this exam. I want to speak to the consultant, to the surgeon on call. May I confirm if I'm speaking with Mr. Mann, please, sir?
Yeah, Mr. Mann speaking.
Okay.
Tell me.
Sir, okay, sir. There is a situation I have here. There is an elderly lady who has a coronary failure. She has developed an axillary swelling with a shortness of breath. She had mastectomy 2 days ago and axillary clearance for breast cancer. Incidentally, the patient requires to be admitted in the hospital, but the daughter wants to take her home. And I've advised the daughter against taking the mother home, but she insists that she wants to take her mother home. So
Okay.
that's the
Okay, doctor. What do you feel? Is her daughter pursued her in making this decision, or the patient made herself this decision?
is the daughter that is persuading the mother to make this decision because they live she believes that they live far from the hospital and it's difficult for her to be coming to the hospital to see her mother, and they had this the mother um, she believes that she will take care of the mother more at home, but I've explained to her that the mother just had a mastectomy 2 days ago with an axillary clearance for breast cancer. So she's supposed to be admitted so that to monitor her vital signs and for complications that might arise from the disease.
Okay. Uh, can you tell me what is the reason behind this axillary swelling, doctor?
Okay, it's possible the axillary swelling which she's having is possible. It can be from an axillary vein thrombosis. It can also be. It's possible that it can also be from a lymphedema of which was arising from the axillary clearance, which can arise from from the axillary clearance for the breast mastectomy. So I also believe that the chronic outlet obstructive pulmonary obstruction which the mother has, would also affect her management. So she needs to be in the hospital.
Okay. Doctor, is there will be a surgical drain in the axilla still there?
Yes, there is a drain in the axilla, and the drain in the axilla is still draining a copy of effluent, which is still present.
Can you tell me the output
Okay,
of the
the
drain,
output
doctor?
of the drain, it's I will check and get back to you on the output of the drain, but it's not yet less than 50 mils for 3 consecutive days, sir.
But doctor, the patient is POD 2, right?
Yes, sir.
Okay. Doctor, the drain output, is it blood, frank blood, fresh blood, or it is a clotted blood,
Okay.
venous blood?
Okay, the drainage output is effluent, which there is no fresh blood in it.
Okay. Is the patient is sufficient to make alert to make her own decision, doctor?
The mother is too fragile. The patient is not sufficient to make her decision, but her daughter is persuading that they want to go home.
Okay. Season. Have you done any mini mental scoring? or any abbreviated
Yes,
abbreviated test?
yes, able to make her own decision. So I've told the daughter that if she so insists that she wants to take her mother home, that she has to sign some legal documents for me before I would advise, I will allow her to go home against the medical advice, because ideally the mother should be in the hospital.
Yeah. So what will be your plan of action, doctor?
My plan of action for this fragile elderly woman with a chronic outlet with a COPD and left ventricular failure with axillary swelling on the second day of post-mastectomy would be to, since I've advised her daughter against taking her home, and then the mother can't be able to make the decision on her own, is for the daughter to sign against the medical advice stating that she understands the implications of her actions and that she will bear consequences if by any adventure the mother develops some complications at home. Then I'll also leave my number with the nurses in case they, when they get home and they want to contact me. Furthermore, I would also organize a social at home if the daughter so insists that she wants to take her mother home.
Will you discharge the patient on drain, or you will remove the drain, doctor?
I would leave the drain inside too, but I will make sure that I will contact a GP that is close to our house that will go and that will be monitoring the drain, or social workers that will be monitoring the drain, so that if it's less than 50 meals in 3 consecutive days, then I will advise them to remove the drain. But if it will also be possible, after removing the drain, after 3 days, they can also come to the hospital for removal.
Doctor, but you said the daughter is living so far from the hospital. Will she able to
Yes.
take her daughter, take her mother to the hospital?
Advise that they should come to the hospital.
Okay. So you will write a letter to
Yes, I will write a letter to the GP or social workers around their area, stating and advising them on the care of the drain.
Okay. And you have tried your best to convince the doctor that the premature discharge will not be in the favor of the patient
Exactly,
health.
sir. Yes,
Right,
sir.
doctor?
I've already done that, sir. And I've convinced her for more than 20 minutes, but she has insisted that she wants to be discharged against medical advice, sir.
Okay. So you do what is required. So you will, if she's insisting to go home, you
Yes,
will do the legal work.
Yes,
and
I
let her
will
go.
let her go. So, sir, what I've discussed with you, sir, about this fragile elderly lady with a left ventricular heart failure, whose daughter, who is taking care of the mother, wants her to be discharged against the medical advice. I've tried to cancel her against it, and I've also explained the medical implications of her taking her mother home, but she still insists. Then I've already brought out a legal forms for her to sign, stating that if any complications arises, that it will be at her decision. Then I've also dropped my number with the nurses, just in case they change their mind and they want to come back to the hospital.
Okay, thank you.
Thank you, sir.
Okay, good. So, yes, give the feedback first.
See, start the communication skill. The initial was slightly wrong, because you have to take out the server and then start that I'm working for this. We have done this surgery, and I wish to call to this consultant rather than explaining in the start. Then you come on the first point, and you at the multiple time you said the same thing. The patient is POD2
Fragile.
and have a mild left failure and fragile. I don't think you should repeat these things, repeat again and again at every point. because it will take you a lot of a time
More time,
actually.
yes.
Yeah, and in the last you can simply said that as we have discussed with this lady, I have as you have discussed, the drain will be the patient will be sent with drain in situ, and the GP will take care of the drain, and I will write a letter to the GP as well as the social worker, and we will get a legal document signed as discussed with you, sir. But I
Yeah.
think that will be sufficient.
Yeah.
Okay, thank you, sir.
This we
Thank you,
just
sir.
discussed
you, thank you.
yesterday that ISBS or what we discussed yesterday, that introduction. But I think how he began taking or the conversation, Dr. Daniel, it was good because he didn't waste too much time. He just confirmed if he's talking to the person he wanted to. And when you said, can you summarize your case? Then he summarized it. It began off very well, but then in the beginning, like you said, he was repeating the same information again. He could have just said the patient has, or the mother has, or whatever, just to save up the time. That's why it took more time. And at the end,
Okay, ma'am.
exactly, if he could just summarize as we have discussed or as you have instructed me, because here you're calling the boss, on-call surgeon, the consultant, and what consultant has advised you or discussed with you. So as we have discussed or as per your instruction, I'm going to do this, and good.
Okay,
Yeah,
okay,
yeah,
ma'am. Thank
good.
you, ma'am.
This will save your time. Good.
Thank you, ma'am.
Thank you.